Many thanks for the invitation to join in with your webinar. My name is Jerry Brock, and I'm incoming president of the International Society for Sexual Medicine. This is a great opportunity for us to be able to provide new information to all those people electronically and virtually who want to learn about sexual medicine. So I commend the APSSM. Our core value, of course, is that we believe that every human has the right for a healthy and satisfying sexual life. Our mission and purpose within ISSM for the last 40 years has been to try and be a credible source of human sexuality information, be a leader in credible information in the field of sexual medicine through our journals, webinars, and in-person meetings. The delivery of this information is really critical to our values. Also, we have a series of different affiliate organizations in addition to the Asia Pacific region that, of course, you represent. We now have well-represented affiliate societies in North America, South America, Europe, and Middle East as well. And so this allows us the reach to really get that information out to so many different clinicians and to the public at large. The idea that we're able to distribute that information is really on the basis of the fact that we have this whole family of journals, and they all do slightly different things. The Journal of Sexual Medicine is really critical for systematic reviews. They deal with basic science and really have state-of-the-art information to those people who are dealing with high-level scientific impact studies. Sexual Medicine Reviews is slightly different. It deals with review articles that are clinically important and provides the clinician with up-to-date information on various topics. The Open Access Journal in our family of journals allows wide distribution of your research and your papers because it is in fact open access and it's widely distributed free of charge to everybody. Finally, as a surgeon, the idea of having a journal that is a prosthetic journal and allows us in a video format to provide information about new surgical techniques is critical. Over the last couple of years, with the various problems that COVID has represented to all of us clinicians and scientists, the idea of having these electronic and virtual meetings has been critical to our growing success that we've experienced. And this is just a small representation of some of the events that have occurred dealing with female sexual dysfunction, vulvodynia, hyperactive pelvic floor, new therapies for erectile dysfunction, diabetes and sexuality, and a whole range of other topics. And we plan to continue with these. So on behalf of the ISSM, thank you for partnering with us. Thank you for all of the critical work that you're doing in the field of sexual medicine. And I wish you a very successful webinar. Bye for now.
I'm Koichi Nagao, President of APSSM. Congratulations on holding the scientific conference of VSSM 2022. 5 years ago, I attended Vietnamese Society for Sexual Medicine, held at Imperial Hotel at Van Tau. I would like to thank you, Professor Dan Mai Van Tien, and the other staff for their hospitality. The members of Vietnamese Society were very personable and full of energy, and I felt that they will develop in the future. That is why it's great to have online knowledge exchange for information, education, and professional development in human health. I'm confident that the scientific conference of VSSM 2022 will be a success. Thank you.
Hello, everyone. I'm Dr. Dugam Moon, working Korea University Hospital in Seoul, Korea. And it's my great honor and pleasure to moderate the first ISSM-APSSM webinar in conjunction with the VSSM meeting. I appreciate the committee members of the ISSM, APSSM, and VSSM for their organization of this webinar, and I hope more successful collaborative program in future. Please welcome Dr. Jiang Hui, co-moderator of this webinar. He is a president of China Sexology Association and Global Chinese Society of Andrology and Sexual Medicine. Today, we prepared a presentation from excellent speakers of the APSSM with a hot issue of their area. And Dr. Jiang will introduce the first two speakers, and I will introduce the last two presenters. For fluent processing, Q&A session will be held after completion of all four presentations. And please send your questions through the Q&A feature in the Zoom and indicate to whom they are addressing your question. Dr. Jiang, start please the first two speaker introduction.
Thank you. Dear Professor Jerry Brock, Professor Nago, Professor Mu, friends online, good afternoon from China. I'm Hui Jiang from Peking University First Hospital. Today, we are very honored gathering here to attend the joint webinar of ISSM and APSSM. And thanks to the great job of the organization committee of these events, we are able to share our thoughts with old friends during the COVID-19 pandemic online. As an important component of ISSM, APSSM has contributed and witnessed the fast growth of ISSM during the recent years, and the expansion of ISSM influence in Asia has further fed back the development of sexual medicine in Asian countries. So today is another chance for us to flourish the development of Asian sexual medicine by sharing the wisdom with each other. Today, we are gonna have Professor Yuan Yiming is the first speaker. I introduce Professor Yuan. The replacement treatment of testosterone is attracting more attention than ever before during the recent decades, and it's now considered the proper timing for drug use. Professor Yuan Yiming from Peking University First Hospital will give his lecture today with the topic testosterone and fertility, how to balance man hypogonadism and reproduction. Please, Professor Yuan. The second speaker is Professor Conrad. Professor Conrad is the president of VSSM, and recent years the VSSM are now on its way of the fast development under his direction. We are honored to have him to share with us the experience of society operation and more details by giving his lecture, Vietnam Society of Sexual Medicine, and the man has initiatives by the Vietnamese government. Thank you.
Thank Dr. Jiang for kind introduction of the first two speakers. And I will introduce the third presentation is penile surgery in China by Dr. Dai Yu Tian. And Dr. Yu Tian is working at Nanjing Drum Tower Hospital, Nanjing University Medical School in China. And he is vice president of Chinese Society for Sexual Medicine and Andrology, and almost important institute, act as a vice president after supporting Dr. Jiang Hui. And he is now a board member of the ISSM. And the last topic is the advances in varicocele surgery by Dr. Jackie Dorsa from Indonesia. And he is also the president of the Indonesian section of andrology, urology, and working at Udayana University. And I met him last Miami meeting. Thank you for meeting again. And so now Please enjoy the outstanding presentation and give more questions. Let's start.
Hello, everyone. I'm Dr. Yuan Yiming from Peking University First Hospital of China. It's my great honor to participate in this webinar and bring you a lecture, Testosterone and Fertility, How to Balance Hypogonadism and Reproduction. Before starting my lecture, I would like to thank the two moderators, Professor Du Junmeng and Professor Jiang Hui. The former is the current president of APSSM, and the later is the incoming president of APSSM. In addition, Professor Jiang Hui is also the president of our hospital and the president of the Chinese Sexual Society and the leader of Chinese sexual medicine. As you all know, the secretion of testosterone is regulated by the negative feedback of the hypothalamus pituitary testis axis. Gene RH secreted by hypothalamus enters the pituitary to stimulate the production of LH and FSH. FSH and LH enter the testes through the circulatory system. FSH acts on Sertoli cells and stimulates spermatogenesis. LH acts on Leydig cells, stimulates the production of testosterone. Testosterone and DHT reduce the secretion of gene RH at the hypothalamic level, where estrogen reduces the release of LH and FSH at the pituitary level, so as to maintain testosterone in the optimal range. If the testosterone level in the testes is affected by the negative feedback regulation, which leads to the decrease of testosterone secretion, it will inevitably affect the spermatogenesis. Intratesticular testosterone concentration is 50 to 100 fold higher than serum testosterone. High concentration of intratesticular testosterone is essential for spermatogenesis. The four main steps of testosterone regulate spermatogenesis include 1. The maintenance of the blood test barrier. 2. Completion of meiosis by spermatocytes. 3. Adherence of implanted spermatocytes to Sertoli cells. 4. The release of mature sperm. The abnormal increase of serum testosterone level or estrogen level will inhibit the production of testosterone through its negative feedback mechanism. Male infertility patients without a history of exogenous testosterone use may have several types endogenesis hypogonadism listed in this slide. Next, we will introduce the clinical treatment of several endogenesis hypogonadism. Kierman syndrome is the most common congenital form of hypogonadotrophic hypogonadism. Treatment of the delayed puberty and infertility associated with Kierman syndrome is achieved by coordinated administration of gonadotropins. Testosterone therapy is used to initiate puberty in these patients, and later HCG and HMG are used to induce spermatogenesis. Hyperprolactin animal may be owing to a pituitary adenoma and warrants further workup. MRI of the pituitary can further characterize the lesions as either a macroadenoma 1 cm or larger, or a microadenoma less than 1 cm or normal imaging. Treatment of hyperprolactinemia depends on the size of the lesion. Microadenomas are treated with dopamine agonistes, which suppress the production of prolactin. The presence of a macroadenoma was an indication of surgical resection. With treatment, patients have been shown to have normalized testosterone levels, improved libido, and better erectile function, as well as improvements in sperm count. Patients with Klinefelter syndrome have an extra X chromosome. These patients open with non-obstructive azoospermia and hypogonadism. Microsurgical testicular sperm extraction has become the care for these patients with sperm retrieval rates ranging as high as about 70%. If the patient needs to have offspring, direct testosterone should be avoided in order to treat hypogonadism. Estrogen is an important negative feedback signal of HPG axis. Testosterone is converted into estradiol by aromatase in peripheral tissues. Estradiol then directly acts on the hypothalamus and pituitary to produce strong inhibitory signals, inhibiting the release of gene RH, FSH, and LH. With the increase of serum estradiol, the serum FSH, LH, and testosterone levels of men with hyperestromalatemia were lower. Obesity is the most common cause of hyperestromalatemia. The adipose tissue contains aromatase, and the increase of adipose tissue will lead to the conversion of testosterone to estradiol. Aromatase inhibitors can not only reduce hyperestromalatemia, but also increase testosterone levels. Losing weight can improve the testosterone-estrogen balance. Hypogonadism, defined as inadequate gonadal function, is a common clinical condition affecting men's fertility and sexual health. In the United States, about 40% of men over the age of 45 years were found to have low serum testosterone. Below normal serum testosterone levels are being encountered more often in men seeking fertility. In China, with the cancellation of the birth restriction policy, more men over 40 years seek to have a second child. At the same time, they may be receiving testosterone treatment to improve their hypogonadism, but this treatment may be damaging their fertility. Internationally, 3 to 4 lifetime prevalence of steroid abuse in men has been reported. This prevalence is estimated to be much higher among young gym attenders, reaching up to 25%. The abuse of testosterone may damage their fertility and cause subsequent male infertility. Male patients presenting with both infertility and exogenous testosterone use have become increasingly common. Hypogonadal patients should receive appropriate consultation on the fertility implication of testosterone treatment. The actual situation is worse than we predicted. Some studies have found that among young fitness men, 93% began use anabolic androgenetic steroid after the age of 18 years, and 81% reported using more than 400 milligram testosterone per week. Prescription amount of the androgen increased more than threefold from 2001 to 2011. The number of doctors prescribing testosterone, including urologists and andrologists, has also increased over the years. This phenomenon shows that doctors lack corresponding training on the damage of exogenous testosterone to fertility. Male infertility requires active spermatogenesis, which depends on Leydig cells secreting high levels of endogenous intratesticular testosterone. However, physiological levels of exogenous testosterone actually exert negative feedback on the HPG axis and subsequently reduce FSH, LH, and intratesticular testosterone concentration. These hormone changes can lead to azoospermia, oligospermia of normal semen perimeters, and testicular atrophy. Before the initiation of hormone therapy, the potential negative impact on men's fertility must be discussed, particularly when that therapy includes exogenous testosterone. Before initiating testosterone therapy in a young patient, it's to thoroughly discuss the risks and benefits and even obtain written consent, as well as obtain a baseline semen analysis. We should inform them of some data on fertility impairment and recovery after testosterone use. Some treatment recommendation for hypogonadism and normal males. No wish to preserve his fertility, no treatment for spermatogenesis. In other words, if there is no reproductive requirement, the indication for testosterone replacement can be expanded. If you wish to pursue a family more than 1 year after testosterone replacement, from time of initiating therapy with testosterone replacement plus HCG. If you attempt to conceive, one step discontinuation of testosterone, but the continuation of HCG. The second step, HCG plus HMG and other medicines such as clomiphene and recombination FSH. To male infertility with hypogonadism, exogenous testosterone use be discouraged. We should make the diagnosis as clear as possible and look for correctable secondary causes of hypogonadism. Therapeutic medicine include clomiphene, HCG, and aromatase inhibitors. At the end of the lecture, I made a summary as follows. Multiple endogenesis causes of hypergonadism may adversely affect a man's fertility potential. Exogenesis testosterone is widely used in normal males. Exogenesis testosterone is a known and common causes of infertility in men. Exogenesis testosterone should be discontinued in any male trying to achieve pregnancy. Supplement therapy to stimulate spermatogenesis may be necessary. Thank you for your attention. Best wishes to you all. Thank you.
Dear Professor Joram Brock, Professor Koichi Nakao, Dear Chairman Professor Du Keo Moon, Professor Chang Wei, I am Nguyễn Quang, President of Vietnamese Society for Sexual Medicine. It's my honor to have a talk in this special APSSM-ISSM virtual meeting. My topic is VSSM and Men's Health Initiative by the Vietnamese government. Vietnamese government announced a book towards people's healthcare coverage with national initiative and the role of international cooperation. We have some key challenges in implementing nationwide healthcare coverage about essential medical services. Vietnam is one of the 10 countries with a record of rapidly achieving the Millennium Development Goals on health, but there are still major disparities between regions and ethnic groups. Government investments have expanded and upgraded the network of provincial and district hospitals. Commune health stations cover 99% of communes, wards, and towns nationwide. However, there are still large and persistent differences in health indicators between localities, ethnic groups, and living standards. For example, differences in malnutrition, child mortality, and the ability to access essential services. The capacity of health facilities in rural areas, mountains, and islands is still limited, especially the lack of qualified and experienced medical staff. Quality assurance systems have been established in all hospitals. Diagnostic and treatment guidelines have been issued for various diseases and are being applied in hospitals. Professional training is gradually shifting to focusing on competencies rise from the undergraduate level to the graduate level. However, in this hospital-centered health system, communal health stations have not yet met the primary health care needs of the people. Health workers are often not qualified, lack of skills in professional areas such as first aid, early detection and management of non-communicable diseases, and few opportunities for ongoing training. The list of drugs that commune health workers are allowed to prescribe is very limited. There are few conditions to perform tests and diagnostic imaging. As a result, patients have little confidence in the quality of primary care services and often choose to go to a higher level, even though they themselves incur higher costs and more cumbersome procedures. National plans and policies toward nationwide healthcare coverage about innovation of service provider is relevant the primary healthcare system. Resolution 20 of the Central Executive Committee year 2017 on strengthening protection, care, and improvement of people's health, shifting the focus on health protection, and building a medical foundation at the primary level from the district level and below. The national strategy to protect, care for, and improve the people's health for the period 2011-2020 has emphasized the renewal of the primary health care in order to fulfill the national health goals. And in 2016, the Prime Minister promulgated the project on building and developing the primary health network. Currently, family medicine principles are being implemented, especially at commune health stations, in response to the rapidly aging population and non-communicable diseases. Invest in improving the professional capacity on health workers. The Ministry of Health has developed a health workforce development plan. Recent activities have focused on pre-practice professional training, building competency-based training programs for doctors and nurses, training to update GP knowledge, and expanding the scope of their primary health care practice. The number of establishments eligible for continuing medical training is increasing, while continuing to rotate professional staff to support the capacity building of lower-level medical facilities. We have many Vietnam societies participate in the field of men's health care, such as Vietnamese Society for Sexual Medicine, Vietnam Urology Nephrology Association, Vietnam Association of Gynecology and Obstetrics, Hanoi of Society Assisted Reproduction, and Ho Chi Minh City Society for Reproductive Medicine. And this is the biggest society, Vietnam Medical Association. Vietnamese Society for Sexual Medicine. In the past, most members are doctors from urology department. Center for Andrology at Việt Đức University Hospital and Andrology Department of Vision Hospital established in around year 2000. And then we have more andrologists. In 2010, Vietnamese Society for Sexual Medicine was established with more than 300 members at the beginning. Vietnamese Society for Sexual Medicine is a voluntary socio-professional organization of doctors, pharmacists, engineers, bachelors, and Vietnamese organizations operating in the health sectors interested in andrology and sexual medicine. The purpose is to unite together to protect and improve people's health, contributing to building Vietnamese medicine step by step to meet the requirements of industrialization and modernization of the country. This is the photos of Vietnamese Society Sexual Medicine National Conference in 2021. VSSM collaborate with medical training facilities and universities to organize CME courses for medical staff. VSSM and research. We encourage members to promote scientific research, join research groups, and actively publish research results, etc. VSSM collaborate with universities and hospitals. We collaborate with Vietnam University of Traditional Medicine, University of Medicine and Pharmacy, Hanoi Medical University, Huế University of Medicine and Pharmacy, Phạm Ngọc Thạch University of Medicine, Việt Đức University Hospital, and Bình Dân Hospital, etc. Vietnamese Society for Sexual Medicine holds the media for medical staff and people nationwide. About expansion and membership development, we cooperate with other professional associations, developing branches under health departments of provinces and cities nationwide, and development of freelance members, etc. This is a photo with Dr. Nguyễn Thị Ánh, Director of Health Department of Hưng Yên Province. VSSM and international cooperation, especially with ISSM. The number of ISSM members who are Vietnamese tends to increase. In 2020, we have 27 Vietnamese ISSM members, and in 2021, we have 32 members, and in 2022, we have 47 members. We perspective. We increase the number of Vietnamese who are ISSM members. If possible, if permitted, we will try to hold APSSM and ISSM meeting in person, and if possible, ISSM meeting in person in future, if permitted. This is my participation and our participation in ISSM International Visual Meeting last year. Take-home message. Even we have some key challenges in implementing nationwide healthcare coverage. For example, essential medical services. For example, quality of medical services. But we have national plans and policies toward nationwide healthcare coverage. We strengthen the primary healthcare system. We have several Vietnam societies participate in the field of healthcare. And the VSSM Advanced Health Initiative by the Vietnamese government, we have several CME courses for medical staff. We have many research. We collaborate with universities and hospitals. Expansion and membership development and international cooperation, especially with ISSM. Please don't let the man alone in the garden. Thank you.
Dear Chairman and ladies and gentlemen, I'm very glad to be invited into this education seminar. I'm Dr. Yu Tiandai from Nanjing Zhuangtao Hospital, China. Today, I want to give a report on the implant penile processes, current challenges, and future prospects in China. As we know, erectile dysfunction is one of the most common diseases during our clinical works. We all know that the treatment of erectile dysfunction, including non-invasive treatment and invasive treatment. According to the Massachusetts questionnaire, that the morbidity of erectile dysfunction reaches 52%, which in the male older than 40 years old. Most of them are mild and moderate erectile dysfunction, which can be treated by medication and the treatment of the primary disease. While about 10% of them are severe erectile dysfunction, which needed to be carefully estimated and treated, and even needed to be treated by the surgery. Implant penile processes surgery is important for those patients seeking surgical treatment. It's just like the nuclear weapons of treating erectile dysfunction, so that we can be proud of the fact every erectile dysfunction patient could be treated. For surgery treatment, there are many methods previously, but now IPP surgery is the most popular surgery carried out the erectile dysfunction treatment. IPP includes semi-hard, semi-rigid processes and controlled processes. The indication of IPP surgery is refractory erectile dysfunction. For those patients cannot be treated by drug or other treatment, refractory erectile dysfunction includes nerve injury-induced erectile dysfunction after prostate, bladder, and colon cancer surgery or pelvic trauma surgery. Most of those patients can hardly recover. Next is the diabetic erectile dysfunction. It is the most common complications of male diabetic mellitus patients. With the progression of the diabetes, erectile dysfunction will be more severe and the efficacy of medication will be weak. Then, severe venous leak erectile dysfunction and the severe psychologic erectile dysfunction and the other types of erectile dysfunction cannot be treated, also the indication for surgery. Currently, the number of IPP surgery all over the world is about 30 to 40,000 per year, in which 20,000 cases was carried out in United States. We can see that the number of surgery increased every year. In Asia, most IPP surgery were carried out in South Korea, which reaches 3,000 cases per year. While in China, the number of IPP surgery is only about 300 to 400 cases every year, according to the data from Boston Scientific and the other domestic surgery reports. The number is keeping increasing every year, but much less. According to the data from Boston Scientific, most IPP surgery were carried out in Beijing City, Shanghai City, and the Jiangsu province. The other province is just started to carry out the IPP surgery. It's like Zhejiang, Shandong, Guangdong, Henan, and Hubei. The number of IPP surgery per Chinese doctor every year. From this, we can see only 3 doctors carried out more than 20 IPP surgery per year in China. Only 6 doctors have more than 10 to 15 surgeries, and 66 doctors have 5 to 10 surgeries every year, and more doctors only carried out less than 5 IPP surgery every year. I believe that there will be more IPP surgery in China with the development of andrology and sexual medicine and the increase of andrologic doctors. Currently in China, there are a large number of surgical candidates. Just like in America, if 20,000 surgeries every year in the United States, which are about 300 million people for the whole country, there could be nearly 100,000 surgical surgeries in China every year, with 1.4 billion people. However, the fact is there are only hundreds of surgeries carried out in China, which means there are a large number of potential surgical candidates that still cannot accept the surgery. The reason could be as follows. First, many erectile dysfunction doesn't seek the medical treatment, especially the elderly men. They don't mind if they have sex in their life, while in Western countries, the elderly men needed a high quality of sexual life. During my clinical works, some patients agreed to accept IPP surgery, but finally they cannot be surgery because their wife and their relatives cannot accept the surgery. They thought that if you still have sex, you will go bad. So this kind of outdated things were behind the promotion of IPP surgery. Second, the average income of China people is still low. Excessive price of IPP surgery, especially imported processing, could be a heavy burden for most Chinese patients with current income. Third, IPP surgery is not covered by medical insurance in China that people needed to pay themselves. While in America, the most of the cost of IPP is covered by medical insurance, especially for veterans. Their insurance can fully cover the cost of IPP, so that there are massive surgeries carried out in veteran hospitals. Next, there are not enough qualified andrology specialists in China, and not enough medical institutes that can provide professional andrological service. Currently, most andrological services are provided by urologists and reproductive doctors. Next, the quality of domestic processes products is not good enough. Currently, there are many brands of IPP products in China, but the quality is not good enough compared with imported IPP. while the variety of imported processes is single and expensive. All these reasons leads to the lower number of eye surgery in China. So what do we do? Now, the most used IPP production include three types. One is the semi-hard, semi-rigid processes. The second one is the 2 sets. Third is the 3 sets processes. In our hospital, Nanjing Drama Tower Hospital, we started to carry out the IPP surgery after I come back to China in 1990. Till now, it has been more than 20 years, and the total number of surgeries cases has exceeded 300 cases. We appreciate Dr. Ren Wang, former chairman of the North American Sexual Medicine Association and the professor of sexual medicine at the University of Texas at Houston Medical Center. He guided and helped many hospitals in China to carry out the IPP surgery. The purpose of IPP surgery is to treat erectile dysfunction and restore their erectile functions. To achieve a free, casual, and satisfied sexual life, and to improve the quality of their family life and increase family coherence. So we think that post-operative patient management is the key to a successful IPP surgery. A successful IPP surgery must include, first, perfect surgical technique, second, good post-operative recovery, third, the most important is that the IPP works well after surgery. To select the indication of IPP surgery is important. And now we use it to think the patient with refractory erectile dysfunction and the other types of erectile dysfunction that hardly be treated by the other medication. Patients who are willing to accept the IPP surgery also included, even though the medications are effective. Pre-operative preparation of IPP surgery is important, which includes, first, penile rehabilitation. In many patients with long-term erectile dysfunction, the size of their penis shrinks, and only small processes could be used, resulting in lower patient satisfaction. The method of sexual rehabilitation. First, we think long-term low-dose oral therapy for PDE5 inhibitor. It has been widely used in erectile dysfunction treatment to improve the blood flow of the corpus cavernosum. Second, the vacuum erectile devices was recommended by AUA to help improve the nutrition and the oxygen supply of the corpus cavernosum, but also increase the size of the patient's penis, prepare for subsequent IPP surgery. Third, intracavernosous injection of the medicine. The method is widely used in the United States, but not in China, because it is invasive and most people cannot accept it. Also, repeated injection could be induce inflammation and thus fibrosis of the cavernosum. And finally, it can induce the Peyronie's disease. Next point of pre-operative preparation is to evaluate the susceptible to skin inflammation. We could pay more attention to skin inflammation for those who lives in a rural area or works in a bad environment. Daily skin cleaner by special detergent is necessary for those patients who avoid potential infection. If the infection existed, surgery should be sustained until infection was controlled and cured. Also, Surgical sterility is strictly required for IPP surgery. Thus, we should carry out skin preparation in the operation room using foam, iodophor, for skin cleaner. If foam iodophor is not provided, we can make it ourselves by adding detergent into iodophor. Next, the surgery should be carried out in a class 100 laminar flow operating room. And also, the number of people who entering and leaving the operating room should be controlled. Besides, keeping the washing the wound with antibiotic solution during surgery and strictly apply aseptic operation. Some aseptic technique commonly used during the surgery are listed. The most important one is the no-touch surgical technique to maintain the surgical area sterility. Second, we should use the double levels of the film, the skin membrane. Third, the operator should wear double gloves. Before, regularly washing the wound with antibiotic surgery. Otherwise, we should use the special personal cooperate with the operation so it can shorten the surgical time. And six, minimize the operation room time. And seven, improves our surgical skills. Previously, I mentioned the post-operative patient management is very important. Some points are listed. One, tutorial of IPP using after surgery. Second, troubleshooting in the use of processes. Unusable water leaks, water bladder, water capsule movement, etc. Third, follow-up system after IPP surgery should be set up. Answer questions and handle various problems from patients in time. 4. Improve communication between doctors and the patients to inform various problems that may occur during and after use of prosthesis and handling method. Prosthesis revision surgery. With the increase of surgical number, most revision surgery is required. The revision surgery is much more difficult than the initial surgery. Thus, we should improve IPP surgical skills to carry out various repair surgeries to relieve patients' worries. This is also a necessary guarantee to improve the quality of erectile dysfunction medication care and promote IPP surgery. So, in the future, how should IPP surgery develop in China? Here I share some of my opinion. I believe, firstly, strengthen the science education and the diagnosis and treatment of andrological disease among Chinese people. I think every andrologist should be also a good teacher on educating and promoting the knowledge of andrological disease, to let people know the damage of the disease and their healthy and happiness and the necessity to seek the medical treatment. Secondly, set up more departments of andrology in more hospitals, both in public hospital and private clinic, and training more qualified andrologists and sexual medicine doctors to provide professional and superior service for more erectile dysfunction patients. Thirdly, promote medical insurance in coverage of IPP surgery to reduce the economic burden of patients by both hospital and IPP companies. Fourth, promote the innovative research on the medical devices, including penile prosthesis, to reduce the cost of penile prosthesis materials. Although imported prostheses are of good quality, but they are also too expensive. Thus, to reduce the cost of IPP surgery, domestic processes are necessary. 5. Imported semi-hard processes to China, which is much cheaper. Most Chinese people can hardly afford the medical service of both of high expensive, especially for those living in the rural area and the remote area. Therefore, there should be a variety of processes, products, including for patients of different income classes to choose from. If IPP of lower cost can be used in China, I believe the number of surgery will be increased a lot, even reach 10,000 per year. 6. Apply novel technologies and the materials to the processes research to improve the practicable and convenience of the current processes. Current IPP requires a strong squeeze on the scrotum, turn on or turn off, so the patient is feel very painful just after surgery, and then the patient can hardly bear. I have heard that a cellular phone controlled electronic IPP was invented by Boston Scientific. Such innovations could extremely improve the satisfaction of patients. I really hope that these products could be imported into China sooner. Finally, we should pay more attention to the sexual life of the elderly man. China has entered an aging society, so we must change the prejudice and the discrimination against the sexual life of the elderly man to improve their living quality. Respect them and encourage them to pursue a happy life. That's all for today. So if you have any question, do not hesitate. Thank you.
Good afternoon, ladies and gentlemen. I am GWK Duarsa from Faculty of Medicine Udayana University, Indonesia. Thank you for the committee for giving me a chance to present my topic on advances in varicocele surgery. I have no potential conflict of interest. Varicocele is an abnormal enlargement of Pumpineal plexus. There are several hypotheses for its etiology, and varicocele occurs in 15% of male population, but up to 80% in male with secondary infertile. The prevalence gets even higher for the first degree relative with non-varicocele. Although most of the patients were asymptomatic, a subset of people may have testicular pain. The varicocele itself has a clinical significance as it can impair the semen quality, especially in higher grade, but it also the most correctable causes of male infertility. The exact pathophysiology of male infertility remains unknown. However, several studies propose a mechanism for which varicocele can result in male infertility. If we take a look at the diagram, we can see that the varicocele may change the hormonal, result in testicular hypoxia, scrotal hyperthermia, reflux, and accumulation of the metabolite, and thus this will impair the spermatogenesis indirectly causing the elevation of reactive oxygen species that may result in impaired sperm function, increased sperm DNA fragmentation. The indication of varicocele repair based on several recommendations and literature. Varicocele repair is typically indicated in male infertility, specifically for those with clinical varicocele and abnormal semen parameters with otherwise unexplained infertility. Then it is also indicated in patients with testicular hypotrophia in adolescent population or having pain-related varicocele. And there are some other relatively new indications as we can see at the diagram. Some publications from Indonesia that already been published stated that the progressive sperm motility before varicocelectomy will increase 2.7 times more likely to result in a spontaneous pregnancy. And the second publication stated that varicocele repair will significantly improve sperm parameter. Retrospective study from Bureau et al. Found that consistently higher sperm retrieval rates for patients after varicocele repair in non-obstructive azoospermia patients. He also stated from the figure on the upper left that show a various testicular histopathological pattern based on spermatogenesis from the condition where there are no spermatozoids to the normal spermatogenesis condition, so that the patient underwent varicocele repair showing a significantly higher testicular histopathologic pattern. Testicular histopathological patterns have a role on successful sperm retrieval rate. The diagram left show that the proposed pathophysiology, how varicocelectomy will improve sperm quality and finally will improve in male fertility potential. The modality of varicocele repair can use radiological intervention or surgical technique. The embolization has no risk of hydrocele as it directly to the vein, so lymphatic vessels are completely spared. This is suitable for those who doesn't want surgery. However, it is high in recurrency rate. On the other hand, the surgical technique can be done in microsurgery or macro or open technique. The first ever open technique will be the open Palomo procedure. And the newer procedure is the open inguinal or subinguinal approach, and this approach is better than the retroperitoneal approach. However, the arterial injury and the hydrocele formation remain high. For the better precision, we can use microsurgery as it results in the better efficacy as well as a lesser complication. However, it requires more skill. The more advanced technology is robotic assisted. But this is quite costly, and then cost-effective efficacy only achieved in high volume cases. According to the data that we have, as seen on the left table, microsurgical varicocelectomy has superior outcome compared to other techniques with the least recurrency rate, least complication rate, and higher spontaneous pregnancy rate. The other advantages of microsurgical procedure compared to retroperitoneal approach were cosmetically better, lesser pain, and better sperm analysis parameter, motility, morphology, and sperm concentration. As the microsurgical varicocelectomy repair is currently seen as the gold standard, quote unquote, then we have to do more discussion on how we do the microsurgical varicocelectomy. We can use an inguinal approach or subinguinal approach. Based on the forest plot analysis of RCT and observational studies, it can be seen that subinguinal microsurgical varicocelectomy has the lowest complication and the highest successful rate. We should make the 1.5 to 2 cm incision in subinguinal exactly below the external inguinal ring. Then the spermatic cord is exteriorized. Spermatic cord was dissected, identify the artery, dilated veins, and lymphatic. After that, the dilated veins are ligated with non-absorbable suture and transected. In order to optimize the result, it is recommended to identify the artery prior ligate the large vein, if it is possible, of course. Then ligate all the spermatic vein. Cremasteric vein can be ligated also when easily accessible. This picture shows principle step by step of microsurgical subinguinal varicocelectomy repair. Incision, isolated the spermatic cord, open the internal spermatic fascia, confirm the cord contains, including the artery, ligate and transection of dilated veins, and finally cord block and wound closure. Optical magnification is essential tools in andrological urology. Accurately identify and define the critical anatomic structure, and loops 2.5 to 4.5 magnification is the most frequently used. But recent advances in imaging technology have led the development of high-definition compact video microscope to perform open surgery that require magnification. Video telescopic operating microscope or FITOM 3D will give the image of super quality with 2 to 16 times magnification zoom and good illumination also. By using the FITOM 3D, the surgeon looks at one screen and the operating position is regardless of the FITOM 3D position. In the other hand, when we use the microscope, the surgeon and assistant will look through the eyepiece, and the operating position of the surgeon widely depend on the position of the microscope. FITOM 3D offers the superior visualization of small vessel and muscle tissue. Adaptation of the 3D is not an issue. Surgeons already used to use the three-dimensional procedure and ergonomically benefit compared to traditional operating microscope. A oscilloscope with a standalone camera is connected to an integrated 3D telescope, a remote control zoom, and focus functionally. Camera positioned above the operating site using the holding arms and adjust the magnification needed from 2 to 16 times. Zoom and focus are controlled via the image one pilot. Some study about FITOM already been published. Mr. Cho and Chu stated that the surgeon found FITOM easy to use, neck strain and fatigue were reduced, and surgical trainee felt that the FITOM imaging aided their understanding of procedure and anatomy. Fragment et al. Evaluate the video telescope operating microscope for pediatric surgery and neurology. He said that FITOM provides an excellent visualization of pediatric procedure with improved surgeon comfort, and it may serve as the substitute of loop. As the summary of the advantages of FITOM 3D, FITOM is an ergonomic system that fully adjusted by the surgeon, assistant, and nurses. It will give a good quality of video and pictures and better visualization of complex anatomy. And everyone in the OR share the same view of the operating field, make it easier to cooperate and create an easier, faster workflow of the OR team. This is more flexible if we compare to traditional microscopes, much smaller than traditional microscope, and it looks like it is cheaper than the microscope. Magnification itself is not depend on the working distance, but if we compare it to the microscope. The disadvantages of the FITOM 3D that user need to get used to perform the surgery using the screen in 3D and not through the optical loop or microscope. And surgical learning curve, is that an issue or not? Because I found that there is no difficulties using the FITOM 3D. This is a short video how we perform the microsurgical varicocelectomy using the FITOM 3D at our hospital. To see the real visualization, we should use the 3D glasses. We can see clearly the vein with its path, and in the left one we can see how we identify the spermatic artery that are not ligate, and this is the last vein that we get. And we try to identify the spermatic core, vas deferens. And zoom out to close the skin using the continuous suture. As the conclusion of my presentation, varicocele repair increase a significant sperm quality, and microsurgical varicocelectomy provide better result, and it is considered as the gold standard for varicocelectomy repair. Phytome 3D offer a new technique for varicocele microligation with its superior visualization, easy adaptation, huge ergonomic benefit, enhanced training learning, but further study of phytome with a large number size is needed. A urologist with andrological expertise can be very helpful in the diagnosis and treatment of the underlying condition accounting for male infertility. In this situation, phytome 3D should be considered. Thank you for your kind attention. Best regard to my colleague, Dr. Widyatmoko, Specialist Urology Consultant.
Thank you for all the speakers for excellent summary and presentation based on their own experience. And thank you for attendance, for listening, for consecutive for lectures. So I'd like to open the Q&A session. And in Q&A chatting, there are two questions. So, Professor Jiang, will you moderate the first two questions? The first question is to Professor Dai.
Professor Tay is there?
I can see that Professor Dai is not in the meeting room anymore.
Not the meeting room, yeah.
Maybe then the question for Professor Dursa can be asked.
I will do. Dr. Dursa, you have a question from the Dr. Tung Mai Batien from Vietnam. I also have some question. Thanks for your excellent summary of the varicocelectomy, and I am very interested in the Phytome 3D. And the first one, which company produced the Phytome 3D? And would you explain your preference of the Phytome versus the conventional microscopic system? Or so which system is more suitable or better for varicocele repair?
Okay, may I answer it directly? Hello?
Please.
Yeah, I can hear.
You can hear me. Hello, sorry. my first laptop is not working as I predict, and I use the second one. So thank you so much, Professor Dung, for your question. And then yeah, sorry to tell you the company that I use stores Phyton 3D. I use it since maybe 2000 early 2019, and then nowadays I already perform more than 50 varicocelectomy using that equipment, and then I feel it is very easy to use the Phyton, especially for you all that who are working at andrology field. Then using the Phyton is not difficult, because as a urologist we also used to perform the surgery using the camera, using the lens. So learning a distance surgery using the Phyton is not difficult. The first one, and the second one, the assistants, the instrument, and also the student will learn more easier if we use the Phyton. They can see the anatomy very clearly, and then there is no difference whether you are using the microscope, as I used to perform until now, to do the varicocelectomy. Even if I do the fasciostomy, it's look like okay. And then nowadays I'm still waiting for the result of the surgery, the result of pregnancy. But so far there's only one hydrocele formation in the last 3 years that I do using the Phyton. Only one hydrocele, and then 2 scrotal odim, but no serious complication using the Phyton. Thank you.
Dr. Dai, can you hear me?
Dr. Dai is no longer in the meeting.
And is there our question in training? Actually, I think that about 60% of the world populations are living in Asia Pacific area, and so the APSSM or Asia is a very good population and a big market, but somewhat heterogeneous, from highly developed and poorly developed country mixed. And nowadays, Vietnam and China, from the lower income and lower aged people, now move to high income and old aged people society. Korea and Japan already. So I think that it's very important, the life expectancy of each member country. So I have a question to Dr. Guang. Congratulations the VSSM joint meeting with the ISSM and the APSSM webinar, and I appreciate your effort for the development and enlargement of the VSSM. What is the number of urologists and andrologists who study male infertility and sexual medicine? Hello, Guang. Where are you?
Dr. Erica, are you here? Would you some question? Yeah.
The microphone is not working.
Then Dr. Yuan, can you hear me?
Yes, I can hear you, but the micro, okay.
Okay.
I
Hear
can
you.
Okay. Thank you for your question. Right now, you know that Vietnamese Society of Medicine, we now raise members of our from nationwide. So right now, we have urologists and andrologists in our society. So many of them can involved in the infertility hormone health. Can you hear me?
Yeah, and I think that it's very important. One is the life expectancy, and the number of andrologists to develop
Yes.
sexual medicine society. As told
Yeah.
the DAI, the low number of the IPP in China, very big population, compared to
Yes.
less than Korea. Korea is the same. We also have a very similar problem. No coverage by medical insurance of the IPP.
Yes.
But the cause of recent steady increase of Korea were the increase of life expectancy and the change of old man's life value, and increase the qualified doctors, including local clinic by commercial advertisement. Now recently, university hospital increase of the IPP is usually increase of the robotic prostatectomy. So it's the same situation in Korea. So I think that the number of the older people and the life expectancy and their economy and their mind or thought of the IPP or importance of the sexual life. So we should educate the general people. I think so.
Yes,
Then
of course.
Yes,
of course, because you know that the life expectancy in Vietnam is also in the same in China. Right now we have more life expectancy, so the demand for IPP also increased. But you know that right now the IPP is only covered by the personal finances for the patients, not the Vietnam, not the insurance. So the cost is most important for the patient. So we have to advise the patient in explain more explanation for the patients how to choose and try to advise them to use IPP. But I think also in the same China, the cost is more important. And also we have to convince the patient to do that. And also, you know that right now for the doctors' experience is most important for the IPP procedure. So we have to train them more skill for the doctors. Also, thank you.
Yeah. Professor Jiang Yi. Jiang?
Yeah, I'm here.
Can you moderate the another question from Katarzyna Wet in the Q&A? Can you see digital health tool?
Professor Moon, maybe you can take over the Q&A question.
And the another audience named Katarzyna Wet, and he or her question is, what is the role of digital health tools in sexual health? And can you leverage personal wearables for better care? So it will be, personally in Korea, some kind of the digital healthcare tools are already applied, like even me, and like the handphone connected watch, they can measure blood pressure, pulse, everything, temperature, even sugar. And recently I developed the avoiding diary or two, and it's the same. Some the electrical stimulator applied for penis penile body can do stimulation regularly. So we are trying the phase control study. So it can be available or for better care. In case die, the upper question to die is the use of the how to determine the proper size of prosthesis during the surgery. Is the risk of tissue damage controllable when we use the model pattern fitting the corporal cavernous? It's a somewhat similar. In the lecture of the Dai, he stated the use of the vacuum device. So regular vacuum device use like that, regular electrical stimulation can give somewhat recovery of or improve the response rate of the PD5 inhibitor like ESWP. And there are many kinds of the personal wearable tools in the future. And I have another question for the Yuan. Yuan, can you hear me?
Yeah, I can hear you.
Recently, clomipene is not available, and frequent injection of the HCG is a big burden for most patients. In patients of the non-obstructive azoospermia, they should accept this kind of option. But in patients of the no azoospermia, only need a TLT in younger age with the age of the fertility. In this kind of patient, recently, we start to use sperm banking. So sperm banking thereafter can use testosterone. What do you think about? I know that there are many sperm banking system, well-organized banking system in China.
I think some oligospermia patient, if they have sperm in his semen, they should collect the sperm to the sperm bank. If they sperm to the, they can have a aesthetic root of the problem. But if they have the opportunity to have a baby, they cannot to testosterone replacement. Actual problem for these patients. They have hypogonadism and they have infertility. So between these problems, they should choose more safer method for their problems. It's my answer. Thank you, Professor Moon.
Thank you. So the reason why I asked such question is at first, the purpose of the TRT is somewhat different. In patient of the oligospermia and in patient who want testosterone replacement and no problem of the fertility. And even in Korea nowadays, the oral testosterone anteriorly is not available. I think that every country is the same situation. So we also, now we have some transdermal, but usually in Asian people do not shaving axillary hair every morning, and So oxycodone is not popular in Korea. So we have only short-acting and long-acting injection and the list nasal testosterone. So it's somewhat different. And if is there dye? Not here. Then Jiang, can you answer the question of Han instead of dye? Then I will. The question of the Han question for Professor Dai, please. How to determine the proper size of the prosthesis during the surgery? Is the risk of the tissue damage controllable when we use the model pattern fitting the corporal cameras? Some fitting devices are somewhat different for every physician who favor, but usually the length is a little shorter is better because the tip injury and the distal extrusion and the circumference girth is in cases of the somewhat small girth. Personally, I put another patch like that. So usually the length is the problem, but the girth is already decided whether you use the malleable or inflatable. So there is no serious concern for tissue damage for size selection. Usually length matter is the problem. So at least 1 centimeter shorter, then you can use a rear tip. That's the better. Is there any question? Jiang, do you have any comment or the suggestion for each presenter or these Vietnam members or the APSSM?
No, I think time is over. We can end of this section. Yeah.
Then
you can conclude. Yeah.
Yeah. Then I'll give some the comment if you want the among the 4 presenters. Do you have no comment or the addition? Then now it's time for closing this ISSM-APSSM webinar with a joint meeting with the VSSM. Thank you for good lecture, for excellent presenters of the APSSM and your dedication for the development of the APSSM and the VSSM. And thank you, Professor Jiang He, for moderating this session. And before closing, I want to announce the next APSSM 2023 biennial meeting will be held in Busan 2023, March 31. Hope to see you all in Busan. Thank you. And please stay healthy against the end of the COVID-19. Thank you.
Thank you.
Thank you. Bye.
Yeah, thanks to the VSSM organization committee and thanks for speakers. See you next time. Yeah. Thank you.
Thank you. On behalf of Vietnamese Society for Medicine, we would like to thank you all for your participation and wish you health and successful. Thank you.
Thank you so much.
Thank you.
Bye-bye.